Hello, my name is John Brink, and we are podcasting on the Brink from the capital of northern BC, Prince George. Beautiful day in Prince George, winter day. Still not quite winter. It's one of those days. We have a little bit of snow, nice sunshine, and we have two fabulous guests today and friends, and that is Dr. Tracey Lotze, who is a medical doctor and an emergency surgeon, and a whole lot of other things in addition to that we're going to be talking about. And then Dr. Jason Boxtart. And Dr. Jason Boxtart, also a medical doctor, not a naturopathic doctor, and an amazing combination. And they are also, I'm glad to say and proud to say, they're also my medical doctors. So, so thank you for being my guest today.
You're welcome.
Our pleasure.
So now, one of the things that I found amazing is that you guys just came back. Can I call you Jason and Tracey? Yeah,
Please,
okay.
yes, definitely.
It's like we do every day.
Yeah, thank you. So you just came back in the last couple of days from the Tough Mudder competition in Los Angeles. What is it?
Do you want to give? It was Jason's first time. This was my 13th and 14th time that I did it. So maybe you want to explain, since you were the beginner this time.
Well, it was quite an experience.
Yeah.
So Tough Mudder was an organization that was created to benefit veterans. I think it was even created by veterans, U.S. Military veterans.
Okay.
Yeah.
And they raised money to help vets. And so what they did was they created a really unique experience where people get to experience controlled adversity.
Yeah.
You know, a lot of people don't really ever get to experience physical adversity in their life very often anymore. We walk to the car, we walk to our office, we walk to the car, we walk home. You know, like nothing really exciting happens all that much. So they've created this experience where you can really push yourself in a controlled environment, but it's also totally not timed. It's not a competition. So you're really moving through this course of obstacles outdoors, but in your own time, at your own pace, with your friends oftentimes.
Okay.
And so it's a real interesting shared experience. And also, and you can walk around any obstacle if you're not feeling comfortable with it and all that kind of good stuff. But the whole point is to be uncomfortable. That's the whole point, is to get comfortable with being uncomfortable. Yeah. Which I really like the idea of. Okay. I really like that idea because, like I said earlier, I think I think adversity in our lives can be a good thing.
So it pushes you to the max.
Yeah, it really
physically?
pushes you, and mentally too. So, for instance, the course was an outdoor course, and it was a 15-kilometer course with obstacles all the way around, probably 20 some odd
They
obstacles.
usually do about
probably.
18 to 20 obstacles.
Yeah, like in that sort of range.
Yeah.
And they ranged from climbing through a mud pit, all the way to climbing over a 50-foot rope wall.
Yeah.
All the way to, for instance, walking through charged wires that give you a 20,000 volt zap as you touch them.
I said, thank you, I'm not going to do that.
It feels like a light tasing, frankly. It's not pleasant at all. It's not even remotely pleasant.
No.
And so you really have to, get into yourself. Yeah. The only thing that got into my head was there was a mud pit filled with water. It was about 2.5 feet deep. Yeah. And just over top of it was laid down a fence, like a chain link fence.
You couldn't get.
And then over top of the chain link fence was a big plastic cover. Okay. So you can't see. Yeah. So it's pitch dark, and so there's about 3 or 4 inches where you can put your face up out of the water into the air.
Is it muddy water? Or?
Yes,
totally. No, that one was the green water.
Well, whatever. It's gross. Yeah. It's muddy green water. It's disgusting. Okay, you don't want any of this. Yeah, right. No. So it's not Kool-Aid. It's not nice.
So how far?
So it's about
100 meters or
No,
50 meters, even
Like
less,
that.
maybe.
Yeah, maybe.
It's a short course, but the thing is, when you're doing it, and so the idea is you're climbing into the water, you're on your back in the water, and all you've got is this fence, and you basically have to crawl along the fence, keeping your head up, and there's enough gap for you to breathe, but you have to keep your head up.
Do they explain it to you before as
No,
to how
not
tricky
really,
it
They
may
just
be?
say, have at her. You got to
know,
figure
if
it
They
out.
say, go.
So the problem was that I was pulling myself on the fence, and the harder I pulled on the fence to move faster, the more the water came over my face.
Not comfortable.
So I was choking on the water as I'm going along, and I can't breathe. And so, of course, I'm thinking, well, I need to go faster. So, but the faster I went, the worse it got.
Panicking.
Oh, yeah.
So the trick was actually to slow down, because when you stop, you can breathe. You're
Fine.
lying on your back, but you can breathe. But the faster you go, the more the water comes out.
Yeah,
So it's
that's the wrong thing to do.
counterintuitive. The answer is counterintuitive, right?
Yeah.
And so, of course, I just went faster. And I got out of that thing choking and coughing and sputtering.
Did you go all the way through?
Oh, damn right.
Yeah, you can't really go back or forth. Like, you
No.
have to go out.
Well,
Once
because
you're in,
there's
you have
people
to
coming
go.
behind you. You can't just say, "Oh, I'm done." Right. So it was. So that was just one of the 20 roughly obstacles. That was the only one I really found challenging. That got into my head. All the rest of them, you can kind of get through, and it's okay. Talk yourself through it. That was really so. So it was an interesting experience. On top of the fact that you have to run 15 kilometers.
Yeah.
And I don't run.
No.
Not anymore.
either.
In a long time.
anymore.
So by the time I got to the end, and so the last obstacle is a ice water bath,
Yeah.
literally with floating ice on it,
Yeah.
in the water.
Yeah.
The water was so cold it stung my skin.
Yeah.
I couldn't even feel how cold it was. It just hurt.
Yeah.
And then we get out of that, and you go to this other, and after that, right after that, you climb the 50-foot rope wall,
Yeah.
and then after that, you run through the charged.
Yeah.
So the end when you're exhausted, got harder.
Right. Yeah.
It wasn't. It's not like they were like pulling off the gas pedal, towards the end to cut you some slack. No.
No.
So in
was
short,
crazy.
it was a crazy idea. I'm never gonna do it ever again.
Well, so to put the icing on the cake, Tracey decides to do the 10K course the next day, just for fun, because what the hell, we're down here, so we might as well do it.
Yeah.
Totally crazy.
Yeah.
So I said, pass.
Yeah.
I'm 55 years old.
Yeah.
I'm dead. Like, I feel like I'm half dead. So I basically ran after her on the Sunday and took video and pictures of her doing all the obstacles and stuff.
Yeah.
And so she was super happy
But
about
we
that.
already bought some tickets for next year.
Yeah.
So yes, so I'll do it again. But at least this time I know what I'm getting into.
So it's a good cause.
Yes.
And then it
Yeah.
tests you to the limit, right?
Yes.
So
Well, to your limit. That's really the neat part.
Because you could even
Yeah.
run at the end. You don't have to go in the ice bath. You don't have to climb over the wall. You don't have to go through the electrical wires, right? You could walk around that, and no one begrudges you. So it's really, like you're saying, facing adversity in a very controlled environment, allowing people to become uncomfortable and go, wait a minute, I can handle this.
Yeah.
That's really the big deal. So that people can see they can overcome adversity in this controlled environment.
Yeah.
So I thought it was an interesting experience. I liked it.
Yeah.
Afterwards.
The thing that comes closest to what reminds me of that, I was in the Air Force Special Forces, and they kind of do things like that.
Sure.
Live
Well, I
bullets
think
over your head
they're
about
trying
that.
to create.
right? Good times.
They're using some of their military
I
obstacles.
got a sneeze. Boom,
That's all you need, right? Yeah.
not
crazy.
again. So yeah.
Anyway,
So that's all good.
so that was that.
Yeah.
So I had to ask that first because I heard about it and I thought I need to know more about that. Just knowing a little bit more about you in particular, Tracey. You been in Prince George for how long?
About 10 years now. I was up in Fort St. James for the first couple of years, and then
You came from South Africa.
Africa,
But trained in South Africa,
Yes.
Johannesburg, I believe.
Cape Town.
Cape
Town. I did some of my training, some of my post kind of study time closer to Johannesburg, but I trained at University of Cape Town. Yeah.
Yeah, and then you came to Canada, and somehow ended up in Prince George, and then Fort St. James because was that one of the conditions they?
Well, at the time, Canada and South Africa kind of agreed they're not going to poach the doctors from South Africa.
Right.
But you can advertise privately. So the clinic, just kind of like many clinics, people don't realize they're technically private. So it's a private clinic, although the doctors all we work for the government, but the clinic itself is privately run. So they advertised in a medical magazine back in South Africa, and I saw their name, contacted them, and then they just put me in contact with the Northern Health recruiting team.
Yeah.
So there is a team that helps doctors move here, but that team is not allowed to advertise. So that's how I ended up at that clinic, only because they happened to advertise.
So you got your training in South Africa as a medical doctor,
Yes.
and then you're also an emergency surgeon.
Well, just emergency physician. So
Physician.
Yeah.
So what's the difference?
Well, the surgeons would do extra training to actually go into the operating room and do major surgeries with regard. So they do have trauma surgeons, and that would be an extra specialty.
Okay.
Definitely something I was interested in, but after going to med school, we do a 6-year program, then you come back then I moved to Canada. Then I had to re-license here and redo all the exams here. So it becomes like you're redoing your training almost again. And at that point, I just thought, I don't have time to go back to school for another 3 to 5 years.
Right.
So it would have been another 3 to 5 years to learn the surgical speciality of it. Yeah.
But you still are on call sometimes, and
Yes,
you are in when there are special cases you are involved in.
Yes. And then I do the sexual assault team as well. So we do on call for that, and that's kind of a specialist team as well.
Yeah. Another thing that stands out about you in particular is that you're also a cancer survivor.
I am.
And you're very involved in the Wheelin Warriors, which are, and so are you.
That's actually how we met, right?
That's how we met, actually.
Yeah. We met when we started training for the Wheelin Warriors together.
Was that last year or
2019?
2 years ago or
2019?
Or was that before the?
It was before COVID. Yeah.
And again, the Wheelin Warriors is amazing. With James and
Karen PJ.
And they've done such an amazing job. They've raised a lot of money in the north, and
it's a really wonderful cause, and what's nice is that money stays in the north, which is also, people don't always realize there are lots of fundraisers that happen for lots of organizations, and I know you guys are quite involved with the Spirit of the North as well, Healthcare Foundation and that kind of thing, but a lot of times you can get caught in a fundraiser where the money doesn't always stay locally. And people don't always realize that. So it's really nice to be part of a fundraiser where we know the money that we're raising is going to stay in our local community and benefit the people that we see, that we know, as opposed to just going to Vancouver and then getting, shared amongst different areas. It goes, right? Exactly, yeah.
Yeah, and they raised here well over $1 million, right? So some very major numbers, right? And then, and then the cancer clinic here, and then UNBC and the medical school attached to it, and now the cancer clinic, And
they're running a lot of new studies at the cancer clinic here, and they're really in the forefront right now of newer techniques, radiation, stuff like that. I mean, one of our teammates, Rob Olsen, would be able to give a lot more information on that. But I've been watching some of the cancer magazines and that just got released, and they were talking about some of the new studies and that being done locally. And again, that can't be done without funding, without support. So all of these fundraisers where we're doing stuff that supports locally makes a big difference to our patients.
Yeah, but I found amazing, and we've done a number of tours through it. Talk to some of the physicians there and the technicians that are there. They're all top of the line at a world-class level. And they explained some to me that, forgetting now the technicality of it, where they can make it very, very small and very precise. That is
and that's really a big change.
Level,
yes.
Right? Mm-hmm.
And I mean, I think I was talking to Jason about this earlier this week, and I was saying with the new work that they're doing locally, it's the radiation changes that are really the big game changer, because patients have a lot of problems after radiation. We talk about chemo a lot, and we know it's hard on patients, but a lot of patients start with radiation. And the reason we use radiation, and again, any of the cancer docs can correct me on this, but we use radiation to shrink things. So people always say, I have a tumor, why don't you just go in and cut it out of me? Yeah. And we say, well, it's big. Sometimes it's big. We don't want to go in there and not make a mess, but if anything kind of messes, we could spread the cancer. It also creates harder surgery to do, and
Right.
there's obviously increased risk of side effects. So if we can shrink anything down to something small, much easier to manage.
Yeah.
But unfortunately, radiation doesn't come without side effects.
Yeah.
And the biggest side effects are the burns it creates. And we talk about burns, and some people will know like the skin will be burnt, but not just that, the tissues underneath get burnt as well.
Yeah.
And it creates a lot of scar tissue.
Yeah.
And that can be very debilitating for patients afterwards.
Yeah.
You know, especially like we think of head and neck tumors. So people have tumors in their neck and that. So we have to give them radiation. But then how do they swallow and breathe properly afterwards if there's burns and scar tissue and contracture in any of those structures in there?
Exactly.
They end up with permanent damage.
Yeah.
So even if they're cancer free, their life is still, you know, negatively impacted.
Yeah.
So being able to really micro focus the radiation to where they need it is a very big change and very helpful to patients.
Yeah, so that's the one. And coming from Prince George,
They're doing it here.
this
some of the new
clinic
studies,
here,
yes.
you know, and you know, at that level is hard to imagine. The other thing that I saw recently on, forget now where it was, but you know, is about new ideas about cancer or detecting cancer much earlier than they were doing before because of, I forget now how they did that, or by you know, when they examine somebody, they can take I don't know how the technicalities are, but basically the conclusion was that it is much easier to find out if you do or do not have cancer.
It's a double-edged sword when the more we get into science and medicine and the more, you know, progress they make, it's amazing because we're getting more treatments, we're getting more cures.
Yeah.
But part of that also comes down into the earlier we can pick something up, the more likely there are times that we're going to be over-treating those patients.
Yeah.
And then we could be doing more harm.
Okay.
Because our body will have cancer in it, malignant cancer in it, many times in our life. And when I say that, we're talking about a number of cells that become cancerous. Our body is then able to go in, our immune system goes in, and it's able to clear it out of our body.
Yeah.
When our immune system can't clear those cells, that's when the cells then can overtake and continue.
Right.
So when we get down to, and you need a certain number of cells, and I can't remember the exact amount, but it's you know, 100,000 or 50,000 or something cells before it becomes like a valid malignant cancer kind of thing for us to find.
Right.
If we're now going into these microscopic levels where we're saying, oh, microscopically we saw something here, now we need to give you chemotherapy, are we over-treating too early
That is
and
dangerous
possibly
too.
creating side effects in patients who may never have developed full-blown cancer?
Yeah.
It's also one of the theories when we look at some patients who claim that they were able to get cancer-free just by praying or by doing energy healing or things like that. A lot of patients go, I was diagnosed and I went on a 3 months to Costa Rica and I stayed at this place where it was beautifully calm and we did lots of praying and I ate good food and my cancer's gone.
Spontaneous remission.
Yes. And part of that is actually because our body can often clear it.
Yeah.
Yeah.
Given the opportunity.
Yes.
Yeah, and that makes a lot of sense, right? So so there's the balance. The other part, you know, so now what you're doing is you're a medical doctor here in Prince George, have been for a number of years, and we'll talk about this a little bit later because you also are active with Jason in Kelowna.
Yes.
And so I just want to talk about Jason a little bit because Jason is, you're such an interesting couple because of you know, the medical doctor and the naturopathic. How can you get it much better than that as a client? You know, so tell us a little bit about the naturopathic practice that you have, and you started that in 2000 and co-started it in 2002,
right?
And it was called the Integrated Medical Approach. What does that really mean?
Well, I wanted to create a practice that was really focused on professional services. So I think that when people think about naturopathic medicine, a lot of times they might think about, you know, buying supplements and all this kind of stuff.
Right,
you know?
right, yeah.
And I think that's a reasonable criticism. I think that it's easy to, like, you know, from a practice management perspective, it's easy to sort of get caught up in that sort of way of doing things. So what I wanted to do was really focus on developing a practice that was focused on professional services and not so much on that kind of practice.
Right.
So that meant that, myself as well as the people that I brought into the practice were going to have the same mindset, and they would also have to pursue continuing education and practice, like build their skill set right into more advanced kinds of things, right? So that we could all be doing the same thing, because we have about 4 naturopathic doctors working in the office right at the same time. And so so that was sort of the early beginnings of it, of the practice. But I guess the integrative part is that I wanted to seamlessly offer to my patients, when appropriate for the individual patient, whether we use prescription medications or we use natural things. Yeah. I wanted to use them all interchangeably with no big bias either way. Right. And so whatever's best for that patient at that time, then that's what we'll do. Yeah. Now the great part of that, about that perspective, is that now I have a very broad toolkit, because naturopathic doctors in BC can prescribe medications. Right. It's very similar to, say, like a nurse practitioner or a medical doctor. Right. So now I can intervene at different, say, earlier on in a disease process, right, and use natural things. Or if somebody comes in, farther along in that process, then I can use prescription things, right, with the idea that eventually, we're going to integrate, everything, and then hopefully require less medication over time. Right. We can, we can use lifestyle modification, supplementation, intravenous therapies, hormone therapies, all these different kinds of things. Right. Bring them all to bear with one patient, and then instead of just relying on medication, say, for instance. Right. You know what I mean? So that's the integrative part. We integrate all of these things for these patients in an evidence-based way, which is a really big deal in my world. And that's individualized for each patient. So we're doing the right thing at the right time for that patient. It's really, really the big deal.
Now, for you've been quite involved in naturopathic medicine. Also, in Canada, you were involved on the board of the Naturopathic Foundation for 6 years or so.
Yeah, I was the chair.
And
I was on the board for quite a number of years, and I was the chair for a number of years for the Canadian Association of Naturopathic Doctors. Yeah, so I was involved in the politics of medicine for a number of years too.
Yeah. And then, when did you come to Prince George? You're from BC.
Yeah,
original.
I grew up in the Lower Mainland, and then came to Prince George in 2002. Yeah, and then quickly joined the board, and I mean, I was also adjunct faculty in the medical school here for a number of years. I've done lots of different things. Yeah, I've had a really interesting career, actually.
You were a presenter there, and you also had a very early career in the grocery business.
Oh yeah, I did. I was stocking shelves and gathering buggies, starting at 13 years old. Yeah. So I was involved in the family business quite early.
Yeah, because the family business was a grocery business, fairly sizable. Was acquired by Jimmy Pattison at some point.
That's right. Yeah. That's right. And that's when that's actually the first time I was unemployed.
And your brother is still
in my life.
And your brother is still in the organization.
Yeah, that's right. Overweighty purchased our family business, and so my brother came on with Overweighty. Yeah,
and Jason went off into the medical school.
Yeah, and then I just said, pork and bees and toilet tissue wasn't for me. So I mean, I'm glad my brother stayed at it. He's super intelligent guy. I have so much respect for him. Yeah, and he's been really successful at Overweighty. But it wasn't for me. No. And so I went back to school. I think I ended up going back to school for almost 10 years or something.
Can I ask you, how old were you when you decided to go back to school?
27.
Yeah, which is old, right?
Not young for university.
Yeah.
Yes. Yeah. And literally started all over again, because my original...
And for how many years?
Well, my original training in university was in business management. Because I was being groomed to run the family business. That was the whole plan. And then that plan changed. Yeah. So when I went back to school, and I wanted to be in healthcare in some way. I think my original plan was to be a physio or an occupational therapist, and then so I had to I had to take like 3 steps back and do all the prerequisites for the science courses that I needed to take in university.
Yeah.
So I think eventually I was in school for 10 or 11 years.
Yeah.
Before I think 10 years.
It feels so long.
It was a long time before I finally finished school for the second time.
Yeah, and
to
then
become an
spend
naturopathic
time
doctor.
in Calgary working with an entrepreneurial character.
Yes, I worked for, I finished that job about 5 years ago now, maybe?
Maybe almost 7 now, yeah.
Something like that. Anyway, so I was working for an organization called Pure North Synergy Foundation, which is a nonprofit funded by a really, really neat guy named Alan Markin. He's the immediate past president of CNRL.
Okay.
And he decided that he wanted to design and then study a primary prevention program for heart disease and diabetes as a wellness program. That started out as a wellness program for CNRL employees. And then my job was to scale it up in BC and then be part of the sort of executive medical team that was running that.
Right.
And be part of the data gathering for all the researchers and stuff.
Right.
So I scaled that up to something just slightly over 20 some odd thousand participants in BC.
Wow.
We were running about a $10 million a year budget, and I was flying all over BC like a crazy person for about 5 or 6 years. Yeah.
And then what happened?
Yeah. Well, so that project sort of wound down. They published a whole bunch of papers on the subject and showed really amazing results.
Yeah.
You know, we showed that we could divert 63% of people away from pre-diabetes in the first year of treatment.
Right.
That cost pennies a day.
Yeah.
Anyway, there was a whole bunch, many papers published on the whole thing. The idea was, Alan's grand idea was to really present our findings and the whole program to government and say, hey, listen, we have designed
This makes sense.
a prevention program that is cost effective, that has been scaled up to a population size intervention.
Yeah.
So we've done a proof of concept. This is all done. And it's all cookie cutter. All you got to do is just do this and you're good to go.
Yeah.
And we designed it to be run by nurses, so it was cost effective.
Yeah. Far too efficient for government, right?
And then they just weren't interested.
Yeah.
I sat down with Adrian.
If you keep
By
everybody healthy,
my
there's nothing for them to
surprise.
do, right?
We sat down with Adrian Dix, and he gave us 5 minutes and showed us the door.
Yeah. Yeah. And
Maybe not even that long.
surprised, right?
Yeah. So it's just, I really feel like, I did the same thing with First Nations Health Authority. I pitched it to them. They weren't interested. Same with the Alberta health government as well. I think it was just too radically different for them.
Yeah.
It was too much of a departure from what everyone knows.
Yeah. Yeah.
And I think it would have been, it was a difficult sell anyway. But
You see, if I look at it, then the whole medical system, no different than the forest industry, is full of politics and special agendas
Absolutely.
and all the other things.
for good or otherwise.
Yeah.
Yeah.
The interesting part, though, is, at least in my mind, is that by and large, the public is becoming more aware or can become more aware. And that's why we have programs like this one, talking about it and saying, how can I be more proactive and understanding?
Yeah.
And like I grew up in the time, although my medical doctor then, 10 years ago, 15 years ago, whenever it was, Dr. Carey, beautiful guy and a good friend, but I would go there maybe usually with things that I plug up here or something like that. And then I go there, sit in the waiting room for 3/4 of an hour, and then my file is already, and it's all full of paper, and he go like through it like this, and although he knew me already, and then we sit there and then said Tylenol or whatever it is, and then say goodbye, and we talk about the lumber industry a bit and all the other kind of thing, and then I'm gone. And that was about the relationship. And then I said, I got to do something different, and then so I then joined an organization, that where they do from bumper to bumper, I call it, annual Copeman, and they assigned a doc, and then once a year or twice a year, that would be my docs, and then and I thought that was a step, at least for me, going forward. And they asked some very good questions, and I was kind of feeling like, okay, they are on my team.
Yeah.
Then something went sideways with them because they sold it to TELUS, and the most hated company in BC is TELUS. And that makes me wonder, why did TELUS buy it? Well, data. That's the reason. Nothing to do with me.
Yeah.
With all due respect to TELUS, so don't cut off. I don't care what they do. So, and then obviously, I became more and more involved, and then became involved with the two of you as my docs, and then, so the model is changing in terms of that the system as it exists. It's better than some other places, but still not, equal. Everybody gets the equal, whatever it may be, service that is available.
Yes.
It's usually underfunded, and then I have to be, if you want to be, then you should have the ability to be more proactively involved, because the more knowledge you gain personally, and the closer relationship you have with your docs or physicians, or then the better chance you have of because at the end of the day, there's only one thing that's important in life, in my opinion, and that is your health. If you don't have your health, you have absolutely nothing.
Yep.
And
part of the problem, I think, in the system at the moment, and again, in South Africa we have a 2-tier system, so we have a public sector and a private sector, and obviously the service you get in each sector is dramatically different. We're talking about in the public sector, if you get admitted into the hospital, you might as well bring your own blankets, bring your own food. We can't promise that there aren't cockroaches running on the floor. It is a very, very kind of thinly spread system. Right? And I worked mostly in that system when I was working in South Africa. We also then have a private system, which is basically offering you healthcare way above anything Canada offers you. I can walk in today, get an MRI today, see a specialist tomorrow morning, but it's something I'm paying for. And a lot of countries use this. India is very similar. A lot of Europe is like this. And then there's a mixed bit of this kind of system in the States as well. Is that a better system? We're not saying it's better. What we are saying, obviously, is people who have more money do have more access, which is not always a fair system. The only problem that I can say as a physician in Canada, however, is because nobody pays, nobody really respects the system as well. And I'm not saying that in a disrespectful way. What I'm saying is you can see your doctor every single day if you want to.
Yeah.
Because it doesn't cost you anything.
No.
Which also means that many people will come in 3 times a week for something they didn't need to come in for.
Yeah.
Which does mean now if your doctor is having to see you all the time for these little things, he's not always available for that other person who's only coming in once for something else.
No. You may have something significant.
And might have something significant. Yeah. And most of the time, patients who are actually legitimately sick don't come in. Yeah. They're the ones who go, I don't want to burden the system. I'm going to stay home and try and see if I can get better.
Yeah.
And then it's the people who are not as sick or who've already been seen once or twice and can probably wait a little while. They don't want to wait. And they don't have to wait.
So why is it? Is it simply saying the politics behind it is that everybody should be equal? Is that the concept behind it, and saying we should not have, a combination of private and
I think that's where what Canada really feels strongly about in their medical industry.
Absolutely.
I do feel that they want everybody to have the same access. And
it's the sacred cow.
It's only as far away as the airport.
Absolutely.
If I go to the airport, buy a ticket, I'm in the States, and I can get
do whatever you want.
So the whole concept of that is already
But by trying to create this, everybody has equal access, they've now inundated the system with a whole bunch of things we don't need, or that patients don't need to come in for, and when we can...
So they have all the liabilities of it, none of the benefits.
Exactly.
Because the system is flawed.
The potential benefits are that if people have equal access, so we know that when you look at the determinants of health, right, which are social and economic, and there's multiple determinants of health, right?
Right.
People that have a low socioeconomic status have higher rates of illness.
Yeah.
Right.
So they're the ones that need the most help.
Right.
And yet, if we had a paid system, right, then the
wouldn't
people
get
that
any
needed the
help.
most wouldn't be getting it.
No.
So that's the problem.
Right.
So then Canada said, well, we need, equal access. Well, okay, that makes sense. But then the problem is that we have equal access.
Yeah.
Be careful what you wish for. And now, so now, we've had essentially publicly paid medicine in Canada now for what? I think 70 years or something like that, or 50 years or something now. Like, people forget that it used to be people used to go bring their chickens in to pay their doctor. I mean, like this happened like only 50 years ago.
Yeah.
Not very long ago.
No.
But anyway, so but now that we have equal access, so the Canada,
unlimited equal access.
Yeah, the Canada Health Act has a few pillars, and one of it is portability. So no matter where you live in Canada, you should be able to get medical care, and also it's also universal access. Right. Those are really the big, huge things in Canada. The problem now is, of course, that when you have people have had this access for so long that I think we've lost the value of it.
They feel entitled. Like, if I want to see a doctor today because my finger is aching, I should be seen today by a physician and get
for a hangnail.
Right?
Yeah,
which
doesn't matter what it is.
The emergency
exactly.
room.
As opposed to someone who goes, okay, you know what, I've got this big burn, or my kid is really sick. So everybody does get in, but what happens is the system is now overflooded with excessive patients because we're making it too easy sometimes, right? If you have a sore finger, you can wait 2 or 3 or 4 days, right? If it's not falling off.
So now the problem is that publicly is saying there are not enough doctors, and so the doctors are they're leaving. They are not continuing to be of service to all of us, and if for some reason they are leaving, and that's a real problem. Well, that's not the problem. There's probably some other problem. So what is the issue on that?
So there's a couple of different factors. I think if we had to look at the true number, there probably is not too few doctors. But when we look at how the doctors are working, a lot of the newer doctors and younger doctors, and even some of the older doctors, are realizing that they can't work 6 days a week anymore. It's just not doable in today's life. So what they're doing is they're also stepping back and going, 1 day a week I want to do teaching, and then 3 days a week I want to work clinic. But now if they're only in the clinic for 3 days of the week, you only have half the amount of access. So what we're finding is that patients just don't have as much access to the physician, and because the physician may be doing more than one thing, number one. Obviously not to begrudge female physicians, but we are finding that they're taking longer breaks, where back in the day, and I know even when I did, I took a couple of weeks off when my kid was born, but they're choosing to take 3, 6, 9, 12 months off now, which does impact, it impacts the patient care a lot, because now you're seeing with 2,000 people who don't have their physician for a whole year. So those little concepts are part of the problem. And then just the fact that people can show up every day. So like when I work at the walk-in clinic, people show up every day because they can. They'll tell you, I was walking in the store and I saw that there was no one in the waiting room, so I thought I'd come in and see you.
It's kind of a visit.
It's kind of a visit. And they're like, I've had this problem for 10 years, but I thought I'd chat with you today, right? Like out of the blue. So the equal access has made it that those accessing the system are not always needing to access it, which then takes away the availability for those who need it.
And then it creates burnout, and it becomes frustration. All of that things that would flow from it. Why is it not acceptable that the mix of the two, private in combination with public, if you wish, are universal? Why can that not be because it already is? Because all I have to do is go to the airport and I have it already. Why is it being resisted? Is that the politicians? Because everybody is so aware of it now. Because wherever you go, you hear not enough doctors, not enough this, not enough medical, not enough nurses, not all of that stuff above, which means it's screaming out for a solution. The no-brainer part of it is combine universal with private.
It's a numbers issue. There's a lot...
From a dollar perspective, Jason?
No, what I mean is there's a lot fewer people that can afford to buy their health care than there are people that can't. And so if you're a politician, remember your primary job is to get reelected every 4 years.
Right.
So what are you going to do?
So if 10% of the population can afford to buy it.
So 90% are going to say universal healthcare is a great idea, right?
Yeah, but what I'm saying is...
Oh, I know what you're saying. I completely understand.
It is.
Because you're being entirely logical. But logical inside of medicine and politics is the wrong way to go.
Yeah, because that's... hey guys,
that's not how it works.
Watching this, that's what I'm doing.
Because, I know. I totally get it. Yeah.
I seldom go to the doc because I'm lucky enough... The traditional ones, and already because I'm trying to be reasonably healthy. But then, on the other hand, I like the specialty. I believe in the combination that I'm lucky enough to have both of you, and and so that makes me feel terrific.
You know, what's really neat about what we do is that we understand each other really well. We work together super well. We think a lot alike.
Right.
People. Somebody's even said to Tracey once, like, you're with a naturopath now. You guys must argue all the time.
Yeah. She was like, you guys must have lots of arguments.
Yeah,
and I said,
like,
actually, we almost
don't
never.
argue.
We don't argue work ever.
We don't argue about medicine. That's for sure.
Yeah.
No.
And I mean, we're nerdish enough that we'll go to dinner and take like some medical magazines and even read that over dinner and chat about it. Right?
That's fun for us.
We both feel very strongly about evidence-based medicine, whether it be evidence naturopathically or evidence scientifically.
Yeah. Now, correct me if I'm wrong. Like for most of the people that go to a doctor physically have to go there and sit in the waiting room. In most cases, it's not necessary. They could do that by phone.
Yes.
Or virtually, just by video.
And so
that's one benefit that COVID did bring us. Prior to COVID, as a physician, we could do only very small amounts of things by phone. Canada and the Medical Society felt very strongly about patients and physicians seeing each other face to face and being able to kind of keep safety in medicine by, or if you see the patient, you know what's going on. But if they're on the phone, you don't know what's really going on. Are you giving the best medical care? With COVID and them asking everyone to isolate, of course, they allowed us to start doing things by phone, and they've kept that now. So it has eased things up quite a lot because now we can do a lot of the smaller stuff. You just need a refill. You're feeling well.
Which is probably 60 or 70% of what comes walking in the door.
It's a big number.
It does, yes.
If not more.
It's a big
so we're
number.
able to now do that and then still see a lot of people physically, but keep, like if you just need your blood pressure medicine, I don't want you in the waiting room with a bunch of sick kids.
No.
Because we're going to make you sick. So we're able to keep some of that out now.
Exactly. And from a funding perspective, that appointments from a cost perspective should be the same as the one.
It now is. It never was before. So
it should be, because otherwise, because if I'm sitting 3/4 of an hour in front waiting for the doc and then seeing him for less than 5 minutes, I may as well do that over the phone.
Exactly. Yeah.
Absolutely.
Because that makes sense for me, it makes sense for my doc, because all I want to do, the reason that I'm sitting there for 3 hours, because I just want to know what should I do about this minor thing, blah, 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 and get some guidance, and thank you very much. Well, there you go.
And there's a lot of times as well, moms are at home, they've got 3 little kids, they may or may not have a car, it gets to, next week's going to be -30 or -40 in Prince George, so somebody's not there to jump the car, it happens to have frozen, didn't start, and they've got a sick kid at home, or something's happening. They can now actually phone in, and we can still talk to them on the phone, and there's certain questions we can ask, and even if someone's sick, there's questions we can ask and actually determine whether it's critical, non-critical, whether they're safe to, maybe give them some antibiotics, or say, hey, wait 2 or 3 days and then come in.
That's the way to go, right? That's the direction. So if I remember from Holland, I remember with my mom, had struggled once in a while, with minor things. But what they would do, they would call the doctor, and the doctor would come over. Yes. Be a long time away from that.
Back in the day.
I used to do house calls as well, and I actually still do house calls. And Jason's even actually been with me on one or two of my house calls. Yeah. So patients who I support to end of life, I do end of life care, even though I actually work at a walk-in clinic. I've had patients where I've had to diagnose them with cancer. They don't have a family doctor. I basically take over their care all the way, and then I'm sitting there with them in hospice when they pass away, and so I would still go do home visits and things like that, and I feel very strongly about that as well.
And so
in certain cases,
so I kind of feel, in a way, from sitting a little bit back, is that it is in transition But soon as it's political, it takes time, and it has to create this crisis from, because the shortage of doctors, because the shortage of this, and what do we do about it? Well, what do we do about it is laying right in front of you. You know, it's a combine.
But the other crux to that, going back to what you said earlier, and again, no offense to anybody, I'm only speaking my own opinion. But of course, as soon as COVID happened and everything was shut down, TELUS did swoop in and take over a lot of online medical care and suddenly cold call people. Patients told me they were randomly called by a TELUS person and asking if they had medications and if they needed a checkup. Now that is not appropriate medical care.
No.
You shouldn't be cold calling people. And they've taken over a lot of the system. They've taken over a lot of the hospital stuff as well. Now they're in charge of a lot of the administrative stuff there, the lab and things like that. So it may be part of their platform that they're extending, and that's okay. It was just done in a somewhat inappropriate way throughout COVID.
Is that TELUS in particular? Or?
Yes.
And so...
Which is really kind of now created more of an expectation by patients, right?
Yeah.
Well, I spoke to this TELUS doctor last week, and they're going to do all these things, but I don't know where it went to. They're ordering me a scan, but I don't know where the scan's being ordered. I don't have the paperwork. Like, we have no access. It's not in the system where any of us can find it again. And then the patients are still having to come back because they go, well, I don't know where my referral is, and I don't know what doctor I'm supposed to see.
Is that not something that should be corrected, though? It's so obvious.
It should be, but the question once again comes down to money and politics.
Yeah.
Right? So, you know.
So is that kind of where the system is trying to correct and then overcorrects?
Possibly, yeah.
You know, so, you know, that sort of thing.
Yeah, so there's a lot of different factors going on in healthcare. And you and I originally discussed it the first time we spoke, where I said it's great that we're getting this mixed system of some virtual and some in person. The question would be is who's controlling it?
Yeah.
And it's rolled out so fast during COVID that I think it's overcorrected and it's almost overshot. Yeah.
With all due respect, you know, when Koopman, I went there for about 4 years. When I knew TELUS was going to take him over, it was obvious to me from, you know, being somebody that reads information and business and all the other, they did it for the purposes of data. Yeah. It's nothing to do with the healthcare. It's just being opportunistic. Not a very popular company, and they should never be involved in that, period, as far as I'm concerned. And if that is, you know, being allowed, then it is overcompensating. But to me, you know, that at least I kind of believe that it is moving in the right direction. Hopefully there is the political goal to stand up to some of these things. And
it's getting tricky now. BC recently released that they want to increase physician salaries and that, you know, and then they were like, we're going to earn all this money. And we don't just earn all that money. You do have to work for the money as well. But what they're basically going to be doing now in the new payment schedule is paying us for more of our time that we do after hours. Yeah. When I'm sitting doing paperwork at home, you can ask him 10 o'clock at night, I'm sitting at my house doing paperwork for an hour or 2 hours every evening.
Yeah.
I'm not getting paid for any of that, right? And so therefore I'm going, okay, well now I'm really tired and the next day I got to work again. And it's those kind of times where we are trying to give our all, where we're not getting compensated. So that's really wonderful with the new payment plan that they want to do that.
Yeah.
But interestingly enough, they're actually dropping our wage.
Yeah.
So our wage per patient is getting dropped by $10.
Yeah.
All they're doing is they're saying we will now pay you for your after hours time. So it's not really going to help because now it doesn't help the doctor to see more patients, but it helps him to do more paperwork.
Yeah.
So I can sit and do more paperwork 10 hours a week and I'm actually going to make the same money as what it is if I saw X number of patients. So I'm worried it's not going to make the doctors work harder in seeing patients.
Yeah, I still believe that, you know, that ultimately the solution lies more in individuals being proactive themselves and saying we are demanding that we like what we have, universality to a certain extent. We already have the ability to do private. Don't stop me from doing that because I'm going to the airport. So that doesn't.
So I'll throw a spanner in the works. WCB pays to get scans and specialists to see patients quickly.
Yeah.
So if you have a WCB case, they pay privately.
Yeah, they do.
And you will get a scan within days.
Yeah.
a scan that might make somebody else who does not have a WCB injury wait 6 to 12 months. So they can pay privately, and the government will take their money and honor that, but you can't.
You see it moving forward to where it will become easier at some point, or it is so deeply enrooted in politics that it will be difficult even if we go forward?
I think it's going to implode a little further.
Yeah.
I think everybody is now trying to grab a life jacket and go, this is the solution, this is the solution. Yeah. They just released now in the last couple of days that they should allow physician assistants to be working. So again, we're going with partially trained, and I'm not saying partially trained, they're trained specifically for their role, but not every role is appropriate. So not every patient wants to see a physician assistant. Yeah. If the physician assistant is available, are you taking work away from the doctor who's prepared to work? Yeah. Right? So those kind of scenarios. Nurse practitioners, that's what they were trying to do with nurse practitioners. So instead of, I don't understand why they aren't micro-focusing on that and saying, let's create more positions for nurse practitioners. Let's train more nurse practitioners, those kind of things.
Are we going
jumping to new ideas.
Just talking about ADHD and just to my guest here, I hope that you have read our book on ADHD. Got it right here, actually. And,
yes.
Now, the interesting part about the book is that post Jason, who was so willing to write comments about it, and then the ADHD, very popular international, as you know, and then the other part interesting about the book is the foreword was very, very interesting, very well done. The foreword was done by Dr. Tracey Lotze. Tracey Lotze. And so the other one that I did is that this other one, Against All Odds, is not about hurrah, hurrah, John, how successful he is, but more for, in spite of it all, I never gave up, and I'm still simply encouraging people, to stay the course no matter what happens. And then I'm going to write another book, and because this one, those were the two, and then and I'm ADHD. Jason has had a touch of ADHD at some point.
Mostly grew out of it.
And so in spite of that, I call it the superpower, and ADHD individuals, as you both well know, we can do 20 things all at the same time, and one of them, I was not very successful in school, but in spite of that, I'm a good writer. And so...
so what's next?
And so the one in July is coming out, and that is finding your passion, living the dream, right? So that I believe that's very important, that people make choices in their life that, and you mentioned it, Jason, as an example, you were already 27 when you then decided to go a different direction. That's the right thing to do, because otherwise maybe you would not have been happy going the other way.
Absolutely, yeah.
And I can say the same thing. I've been a physician now just about 17 years since I graduated. I know I look young, thank you. But I can honestly tell you, you can ask Jason, even when I'm tired, my happy place is at work with my patients. And not because I'm not happy at home and don't like my family. It's not that scenario, but it's my passion.
You can tell of people that they like what they are doing. They, and it's all about, I got a picture of you here. And then I have this other one too, which is a foundation that I believe in. If you wonder what the 2547 is, there are two things about it. It's the price of my books, 2547. But the other one is, 3 blocks from here is the Greyhound station. And when I came here in July 65, I could speak the language, didn't know soul, didn't have a job, and I counted my money at least 3 times, and I had $25.47. But I was going to build a lumber mill, So now I want to build write the book. The third one is coming out. Will be printed in July. It's nearly done. We're getting to the point to get it print ready. So we're getting pretty good at this. With my team. It's always a team effort. And so now I'm writing another book, and I've been thinking about it, and so.
This looks interesting.
I guess we're going to see.
So the title of this book, and that will tell you everything, is Living Young, Dying Old.
I like it.
So, and that's what it is all about. You know, they, you know, I'm still working on the title, but I think it's a good title.
I like that.
Pretty good.
And what it is all about is that doing that, you know, attitude, passion, work ethic, but then even more importantly is that if you don't have your health, both mentally and physically, then you have nothing, and all the other things then are secondary. So, and it deals with those issues in particular.
And I mean, I can attest to that. I see younger patients and older patients who are racked with disease, some other disease process, a lot of it preventable. You know, we look at obesity, we look at uncontrolled diabetes, we look at COPD, which comes from smoking. We look at those things, and then you see these patients at 40, 50, 60, you know, really aged as if they were 80, 90, 100, unfortunately.
Yeah.
And had they been more proactive with their health, they wouldn't have faced a lot of this. And that also puts a big burden on the medical industry, because we're now having to micromanage all the negative outcomes from bad lifestyle choices.
Exactly. And even like myself, and you're my medical doctors, but you know, I'm at 82. I'm still very active, but I'm also proactive in terms of after this interview, I'm going to have a meeting with Jason, and I get an infusion, and so and you, my medical doctor, so I make sure. And you make sure that you know, I'm staying proactive and healthy. And then amazing about this, I'm the oldest competitive bodybuilder in North America.
Yeah.
Not bad.
I'd say that's pretty good.
Yeah.
So
how does it get better than that?
Yeah.
So at the end of this, you know, interesting conversation, obviously, and it always is. So you've been in Prince George for a long time, and you're now looking at also setting up in Kelowna.
Kelowna, yes.
And so is that again integrated?
There's going to be a couple of different aspects to Kelowna. I think one big aspect that we are hoping to do is integrating our medical care that we do as a team even more than we do here.
I like that.
So we're really trying to find a way. We already do that, and we do that with a lot of patients here, but it is a bit broken. They go to his clinic, and then they come to me, and then, you know, and we communicate, but it will be nice to be in one setting. We're also trying to, I think, integrate slightly newer, or just, I mean, I'm hoping to change some of my practice quite dramatically. You're hoping to focus more on your sports injuries, your men's health, your joints, that kind of stuff, anti-aging, you know, how to live healthier for longer.
I do three things really well. I do, some of which we do together. So we do some men's health work together. Hormone replacement therapy and anti-aging medicine for men, and we focused on that, well, because I'm 55 and I want to live a long time, so it's a little bit of that involved there. but I got interested in that, of course, I think just because men are really underrepresented in medicine, I think. And I think a lot of men are reticent to go see a physician. A lot of times they wait until they're half dead before their wife drags them into the office, kind of thing. And so I'm trying to create a more...
And then we're playing catch up.
So I'm trying to create a more attractive kind of practice for guys. And so we do that together. And then
very successfully, actually. Our patients are honestly, really, really happy. It's really wonderful, actually.
It's really rewarding and life-changing for a lot of patients, actually. It's quite something.
So what I'm hoping is that with this book that I'm going to start this summer, I hope that I can call on you two again to be contributors to the book.
Definitely.
You know, so
we'd love to be part of that.
And that now with the place, and I don't want to ask questions that you know, that are too early yet. Is there a name for the new location already? Or are you just kind of still thinking about it? Or?
No, actually, we have come up with a name.
So we have a registered name that, if we can get everything together at some point, we will.
If it all works,
we will kind of create our own brand, I guess, somewhat. So we have registered Omnio Medical. So Omnio is Latin for basically everything. So what we're trying to say is that we provide everything.
Well,
right.
The full scope.
You're not just going to get.
And that's kind of how I looked at you right from the beginning, because it's this unique ability to provide right across the spectrum. My wife Sharon, she is very much into naturopathic. She is vegan, very conscientious of the medical and all of that kind of stuff. So she's very excited about having you take care of me. So
there's one or two other fun things that possibly will happen in Kelowna as well. We've been chatting with another clinic, and interestingly enough, they also do a lot of other therapies that are kind of really not well known to Jason and I. And we're talking about things like psilocybins, right? So mushrooms as part of therapy, ketamine,
psychiatric therapy,
psychiatric therapy, ketamine infusions, which are basically like a sedative that you use and allow people to heal mental health issues and things like that too.
Is that not what you guys are doing? Is that not the future?
That is very much part of the future, in the right place, without a doubt.
I think there's some really interesting emerging therapies in mental health. And I think those are a couple of them. There's a physician that we've been talking to who is interested in that. He's an internist, and he has a private part of his practice, so he works in that area. It's
so
really
much
neat
of
stuff.
an issue today, right?
Yeah.
It's something that everybody talks about all the time right now. Because it comes back to the same thing. If you don't have your health, physically or mentally, you have nothing.
So part of his care as well is also for athletes. So he does hyperbaric oxygen, he does things like that. And so his clinic actually has a chamber, they've got an infrared sauna, and they do all of that with all the other aspects, right? Whether it be IVs, whether it be you seeing me and I'm giving you medications. So they're doing a very integrative approach for all of those things as well. So we're hoping to, stay kind of involved with that as well, because definitely part of what we like. Yeah.
And on the sports medicine side of things, I do platelet-rich plasma injections and injection therapies for chronic and acute injuries. I've been doing that for quite a number of years. And I'm really very advanced in that training and experience.
And it's again a whole new direction, becoming much more broader,
becoming more and more well known out there now. And I'm the largest PRP provider in Northern BC. I think by far. I do tons of it now. I think I do over 200 PRP procedures a year. Just here in Prince George.
Are you going to be still somewhat in Prince George as well?
Yeah, we're not sure. We're not sure how much, but that is the plan. Yes, the plan is still to be back here. We're not sure yet at what intervals. But that is the plan.
So right now we spend a week out of the month in Kelowna, sort of developing practice, making connections, figuring the lay of the land, and then so that the plan is that we're going to move there in the summer. And then probably flip it. So we'll be here a week out of the month, kind of a thing. Because we have a huge patient base here. And frankly, I think that I'd feel guilty if I just left. Honestly, it wouldn't work for me or for her.
And I like that.
We
so for our guests, because we have been talking for a long time now. So just in closing, we covered a lot of areas. I feel confidence in talking to you that we are moving in the right direction. It's a slow process, very political in a way. But for all those people that are watching, they all know it. There is nothing more important than your health. And the better informed you are and the better system we have, may that be a hybrid between universality, although we recognize that, and private, because private not being allowed or tolerated is a bit of a myth, because it's as far away as the airport.
And 20-some-odd% of medicine is delivered privately in Canada already.
Exactly.
Every day.
Exactly. And so my guest today, Dr. Jason Boxtart and Dr. Lotze as well, Tracey Lotze. Thank you for being my guest.
Thank you.
Thank you for having us here.
Yeah.
Thank you.
Thanks, John.
Thank you.
Appreciate your time.